Well, just a disclaimer, I'm actually 9 months pregnant, so if I fall to the ground or go into labor, just FYI.
I was gonna ask, I heard like whatever was on your phone pop up and it was about like an expecting mother or a small child or something. I was like, hold on, I think she has a child around.
Yeah, due next Thursday. So if I fall over, you know why.
Can I ask you a favor? Can we stop just a second the sharing screen? Then once I introduce you, everyone will be able to share. Thank you so much.
Yeah.
Okay, so let's go. Good morning, everyone. Welcome back to Other and First and 15. Today, I'm very glad to have for the first time some participant from the American Rhinologic Society. So today we are going to have an amazing panel with different speakers. Welcome today to Joshua Levy, Andrew Thamboo, Sonya Marcus, and Nick Rowan. Good morning, everyone.
Good morning.
Good morning.
Morning.
Good morning.
Or good afternoon to some of you.
Exactly. Good afternoon or good evening for different states and places. So I've requested my colleagues to have a discussion on different aspects of our daily basis activities, which are the emergencies in rhinology from the clinic to the OR. So today, everyone that are attending are going to be aware of something that we are facing every day. So I will briefly introduce, Joshua will briefly introduce the panel, and every speaker will be allowed to give their topic. Please do remind for all the participants that every question should be asked at the end of the whole panel, okay? So Joshua, please share your screen.
Okay, here we go. So thank you for the opportunity. Speaking for all of us, we're really thrilled to contribute and to join the discussion today. As mentioned, I'm Joshua Levy. I'm a rhinologist now in my 4th year of practice at Emory University in Atlanta, Georgia. And I have a panel of really fantastic friends, but people that I view as the next generation of leaders in rhinology from around the world. We have, going from left to right, this is Sonya Marcus. She is in practice at Stony Brook. Nick Rowan from Johns Hopkins University in the middle. And Andrew Thamboo, who's at the University of British Columbia and St. Paul's Hospital in British Columbia, Canada. We all collectively have no conflicts of interest related to this discussion today. And I will let each speaker mention any commercial interests that they may or may not have. So 3 main topics that we wanted to cover. The goal really was to speak on things that we may see at all aspects of our practices, from acute epistaxis, either in the emergency department or the clinic, to invasive fungal sinusitis, to an intraoperative carotid injury. And with each presentation, if it's not mentioned, I will be sure to jump in and ask if there are any changes in our approaches given the current COVID era and huge importance of increased protection, both for ourselves as well as for our healthcare teams and patients. So the keys to success, in my mind, these topics are not a question of if, but when. We all need to prepare for the inevitable. We need to have protocols and supplies in place and also rehearsed. We do not want a carotid injury to be the first time many of our team members have heard the term. The management plan, while we're presenting it, is universal, and it's important to have steps to proceed. It's also important to be mindful of an individualized patient approach and to be thoughtful as we go through each issue. So with that, I'm going to hand it over to Nick Rowan, who's going to speak on rhinologic emergencies. Nick, if you don't mind switching over, you can drive the ship.
Sure thing. I'm taking over the screen share. You guys good on visualization there? Josh, I see you. Give me a thumbs up. You good?
Big one.
Perfecto. All right. Well, thanks again for having me. Good afternoon, good evening, good morning. A pleasure to be here. Andrew, thanks for waking up so early to be with us today in particular. I have no disclosures for this talk or any talk. And I've been given the topic of acute epistaxis. And I hate for my first bullet point to be US centric. I know that this is an international panel, but this in fact is one of the most recent clinical guidelines published by the American Academy of Otolaryngology. And so acute epistaxis, it's something that is incredibly common, something that 60% of Americans will experience, and a whopping 10% of them are going to seek medical attention for this in one way or another, either acutely or for chronic issues. It accounts for 1.2 million annual emergency department visits here in the US. And of all of the otolaryngology related emergency department encounters, it accounts for a third. So an overwhelming amount. So as Josh told us, we're going to experience it. Many of you on this call already have, and certainly it's something that's part of our daily life and my life as a rhinologist. Like many things in otolaryngology, acute epistaxis has a bimodal distribution and presentation, so very young patients and patients very old, so the extremes of age. And the clinical presentation is based on location. So many of us have learned this early in our training. I know there's a wide breadth of experience on this call today, on this webinar rather. But anterior epistaxis is the most common. So about 90 to 95% of bleeds will be from the front of the nose. Generally, these are self-limited. They can be isolated in nature, whereas posterior epistaxis is a bit more serious, accounts for 5 to 10% of all bleeds. It's defined as not being able to be visualized on anterior rhinoscopy, but it usually has a very difficult, very characteristic presentation, meaning that it is brisk, it can be severe, it can go down the back of a patient's throat. It's typically in older patients, and it's something that typically fails the kind of the first line treatment strategies for the management of epistaxis, such as anterior packing. The anatomical locations that this correlates to on the left side of the screen here, this is Kesselbach's plexus or Little's area in the front of the nose. There's a confluence of small vessels in this area that come mostly from branches of the external carotid artery system, though there could potentially be some ICA contributions. But the superior labial artery, certainly many veins that anastomose here, with contributions from the greater palatine and the sphenopalatine artery. Whereas a posterior bleed, which is on the right side of your screen, generally you want to think arterial in nature, so sphenopalatine contributions, but also feeders from the internal carotid artery system, such as the anterior and posterior ethmoidal system. The clinical presentation, well, most often it's spontaneous without any sort of obvious etiology or inciting event. However, as an otolaryngologist, certainly on your thought process of the differential diagnosis, you need to consider other things that might be causing bleeding, especially when it's recurrent in nature. So is the patient anticoagulated, or do they have some sort of inherent bleeding disorder, or a systemic disease where their platelets don't function, or are they lacking clotting factors? Certainly, you don't want to miss a patient with a tumor in their nose that's causing bleeding, or they have some sort of underlying genetic disorder such as hereditary hemorrhagic telangiectasia or HHT, which might require some sort of unique management strategies as opposed to the standard nosebleed. There are multiple guidelines put out about for the management of epistaxis. They are excellent across the board. I've read through, I've refreshed myself on all of them in preparation of this talk, and they're really great. And they have an algorithmic approach and a stepwise consideration for how to manage epistaxis. And I recommend that you consult one of them. The British Rhinological Society has a great consensus statement. I was really impressed that the French Society of Otolaryngology has not one on the first line treatment of epistaxis, not two on the second line treatment of epistaxis, but 3 guidelines on the management of epistaxis. The third one is on epistaxis in the setting of hypertension. The most recent available guideline is from the American Academy, published in January of 2020, a clinical practice guideline on nosebleeds. which is a substantial 20 pages in length. And so there's a lot in there. And while these guidelines are very extensive and they're great, there are really many parts of it. They're maybe better served towards primary care, emergency physician, and first line responders. And so many of the otolaryngologists are familiar with some of these algorithms. However, there are some nuances that I think are worth reviewing, both in the guidelines and some that I'll touch on here in this talk. So I think that it's really important when you have a patient, you're faced with a patient with acute epistaxis, to do a comprehensive history and physical examination, focusing on their medical history as well as their medication usage, making sure they're not on any anticoagulants, vital signs, and a comprehensive head and neck examination, as well as listening to their heart and lungs, and performing nasal endoscopy is really important. The management of acute epistaxis is relatively straightforward. So topical vasoconstriction, such as oxymetazoline, is generally the first line treatment, along with anterior pressure to the front of the nose, the soft portion of the nose. If a lesion can be identified on anterior rhinoscopy or nasal endoscopy, then certainly a consideration of localized cautery, such as that with silver nitrate, as pictured here, can be considered. But also, if it's hard to identify the lesion and it's anterior in nature, absorbable packing may be a very reasonable first-line option. For patients with more difficult to treat nosebleeds or other considerations, non-absorbable packs are certainly an option. And so I keep on mentioning the word packing. What is packing? So packing is simply putting something inside the nose to provide localized pressure to stop this bleed. There are many absorbable packing options. Whatever country you are from or wherever you practice, you will certainly have different options. I myself work in 3 different hospital-based centers, and in each place that I go to, they have a different absorbable packing option. Generally, they work very similarly. They benefit from being absorbable, meaning that they do not necessarily need to have another intervention to remove them, and that with topical therapies or just time alone, they will dissolve on their own. Non-absorbable options are characteristic sponges. You know, in the US, we typically refer to these as Miracell sponges, but there is a wide variety of sponges. There are ones that have inflatable catheters on the inside of them. I'll show some of them in the next slide. But gauze strip packing is a traditional way of packing the nose, or even putting a Foley catheter in the back of the nose and blocking off nasopharynx to protect the airway is another option. When anterior control doesn't work, or a patient has posterior bleeding, it's really important to keep in mind that you, as an otolaryngologist, it's important to, number one, protect the airway, make sure that your patient is safe, and that should always be your first and foremost consideration. So if blood is going down the back of the nose or down the back of the throat, make sure to keep management of the airway at the top of your mind. And then again, for posterior bleeding, non-absorbable packing options are certainly a good idea. The common pack that I use here in the States is something called an epistat. It's pictured here. It's a dual chambered balloon that allows you to put pressure throughout the nasal cavity and in the nasopharynx as well. When second line treatment options, when posterior packing fails, generally it's time to consider another type of intervention. And those options include a surgical intervention such as a sphenopalatine artery ligation, or ligation of the ethmoidal arteries, or even endovascular embolization. Surgical artery ligation, including sphenopalatine artery ligation, is seen here by videos from Dr. Thamboo, who is on the call. Thank you so much for, again, sharing these with me. Any video I have of sphenopalatine artery ligation has too much blood in it and it's too hard to see. So Andrew was nice enough to give us nice, clean videos to look at today. Previously, sphenopalatine artery ligation was considered a third-line option. However, given its increased rates of success, general ease of surgical performance, and low rates of postoperative hemorrhage, it's really considered now an effective alternative to posterior packing. If a sphenopalatine artery ligation doesn't work, certainly a consideration may be given to an ethmoidal artery ligation. I think this is really important. When you take a patient to the operating room, or when you do a thorough evaluation for epistaxis, it's really important to look at where the bleeding is coming from. Even the most senior surgeons have been fooled on thinking that bleeding is coming from the SPA region. However, there was a vessel that was bleeding on the medial aspect of the middle turbinate that was emanating from the anterior ethmoids. Endovascular embolization is certainly a consideration. However, it does appear that there's some, the average success rate is a little bit lower. The complication profile is a little bit worse than surgical intervention. However, surgical interventions may not always be available. And as Dr. Levy mentioned, certainly a personalized approach is important, and some patients may not be good surgical candidates. So many of these talks have been, and the talk later today in a couple hours will be focused on COVID-19. So how does your plan change? And how does management of epistaxis change for these patients? Well, I think that maybe we are trending towards a little bit more of absorbable packing, and maybe we're considering patients with nosebleeds more like an anticoagulated patient, where you do utilize your first line treatments, but maybe you consider you don't want to expose them to a second procedure, another procedure such as removal of packing. And so I think that's what we're seeing in the acute period in the COVID-19 pandemic. For an anticoagulated patient, certainly you want to consider reversal of whatever medical therapy they're on, or improvement of their coagulation disorder as available. Finally, I think it goes without saying, in my personal experience, I have a large patient population with hereditary hemorrhagic telangiectasia, and these are not just characteristic nosebleeds. These patients, 96% of them have nosebleeds. It characterizes their disease. Absorbable packing options should certainly be considered in these patients if they do require acute packing for an acute intervention, as well as some topical procoagulants. But really, they should be managed by somebody who manages a lot of these patients, and they have some unique strategies such as potentially coblation, intranasal bevacizumab, or really the most robust literature on these patients is on systemic therapy with something like bevacizumab. And with that, thanks so much. Looking forward to hearing everybody else's talk.
Thank you so much, Nick. I really enjoyed the talk. Very, very, very briefly done. Joshua, would you like to have the whole questions at the end of the panel, or from each one of them?
I think at the end would be best, just to conserve our time. But to contradict myself, I did want to push Nick on one question and kind of put him in the hot seat. And I agree. Thank you, Nick. It was fantastic. Given concern for airborne generating procedures and, as you mentioned, operative risks and poor candidacy of some patients, given the evolving pandemic and concerns with surgery, are you in your system or in your own practice considering referral for endovascular procedures earlier than you were before? Or do you have any thoughts on operative versus endovascular control?
Yeah, certainly I would, the answer doesn't go without mentioning that I'm incredibly biased. So I have a surgical practice, and it's relatively straightforward for me to do an SPA. And I'm fortunate enough to practice in a location where we are still quite busy, probably one of the busier centers in the US with the COVID-19 pandemic, but we do have enough PPE. We do have readily testing available. And the complications of endovascular embolization they're severe. And so they are not only facial pain and numbness, but it's visual loss and stroke. And so I think that if a patient needs one of those really kind of second or third line interventions, if you can pack them and you can optimize your team so that the operating room is available, that would be my preference probably. Maybe have a little bit lower threshold for endovascular embolization, but still biased towards surgical intervention.
Thank you. My personal experience is exactly the same as that. The key being appropriate PPE and a surgical team that you trust and have worked with before, if possible. But I completely agree with your thoughts and preference to control this surgically if possible.
So
all right, Andrew.
Perfect. Right, go ahead.
Let's pass the torch to Andrew Thamboo, right?
That's right. Okay, perfect. Thanks, Josh. Thanks, Puya. Great presentation, Nick. So my topic is on acute invasive fungal sinusitis. as you can imagine, as a junior faculty, actually the youngest faculty youngest member on our faculty, these cases generally come to me because they're not usually happening when you're on call. They're the cases that happen when you're not on call or it's after hours. So definitely they come down my pipeline. These are my disclosures. Also, hopefully, once COVID is over, I hope we can all celebrate together at the ENT World Congress here in Vancouver for IFOS 2021. Now, I thought I'd talk about invasive fungal sinusitis using a case. So we have a 63-year-old male with multiple medical comorbidities, which include the following in the past medical history column there: type 2 diabetes, hypertension, chronic anemia, right toe amputation, alcohol withdrawal, and coronary artery disease. And he came to emerge with syncope, dizziness, and polydipsia and polyuria. He was admitted to the ICU for hypoxic respiratory failure and intubated. And that day, on day one, he had a CT scan. And there was not any particular concerning findings from ICU. There was some mucosal thickening, but overall, there's no concerns from ICU, and we weren't called at this point. Now, things continue to evolve for this patient on day 2 and day 3. He continued to deteriorate. There was persistent fevers despite antibiotics. He was awake on sedation, obviously, but awake but non-responsive. He had pupils. Pardon me, I'll just go back here 1 second here. Oopsies. Let me just go back. His pupils were 5 meters bilaterally and non-reactive to light. He had some periorbital swelling, now unable to trace face or blink to threat. So they got a repeat CT scan on the CT report. And again, the CT report was read by the ICU physician, and there's air fluid levels seen within the sphenoid and maxillary sinuses and diffuse mild mucosal thickening in the paranasal sinuses and stable from previous. And obviously, if a ICU physician reads this, it's nothing alarming. But there was an examination done by one of their residents, and there was concern for ENT to be involved. So on day 3, we were consulted for this patient. And on the CT scan, as the CT report, there's not dramatic change. You can see that the mucosal thickening within the ethmoids got worse. But on examination, a very different finding. So on nasal endoscopy, when our residents were called to go see this case, you had the typical finding of invasive fungal disease. And this is actually very extensive. You see the discolored nasal mucosa, the serosanguinous discharge. Very common findings that pale mucosa and of ischemic tissue, the black discoloration, the reservoir formation with crusting. You will find some granulation and some ulceration within the nasal mucosa. And these findings are very typical of the middle turbinate, the septum, and the inferior turbinate. But as you can see in a case like this, it can be quite extensive. I just did a recent case where invasive fungal sinusitis was totally isolated to the sphenoid sinus, and the person presented with cavernous findings. So you gotta have a high suspicion for this disease, even when your endoscopy is not as obvious as this. Now, when it comes to diagnosis, as mentioned, you can get those typical findings as I saw in endoscopy, but past medical history I think is extremely key. And that's what it should just increase your suspicion of at least ruling in or ruling out invasive fungal disease. And I kind of break it up into 3 different categories: immunocompromised, diabetic with ketoacidosis, and iron overload. The typical immunocompromised patient usually has some kind of hematological condition. At our center, we do a lot of the transplantation. So the BMT, the bone marrow stem cell transplantation, the solid organ transplantation are our typical patient. Immunosuppressive therapy, and other conditions such as HIV, cirrhosis, carcinoma, hepatitis, other kidney dysfunctions are also a typical patient population. Now, one other category that's not commonly discussed is the iron overload. These are people who have just a lot of iron in their blood. It promotes bacterial and fungal overgrowth, which can result to invasive fungal disease. So always consider those host factors. So if a patient comes in with some changes, especially neuropathic changes, to consider acute invasive fungal disease, especially if they're immunocompromised, have diabetic ketoacidosis, or iron overload. So after an examination like that, and you see obviously concerning findings, there's really two key parts to this whole management. For me, as an urgent operation, these people are put on the case as less than 4 hours. And the goals of surgery is to reduce the fungal load, remove all the necrotic tissue, and you got to figure out the extent of surgery. And that's usually balanced with medical management because you can do all the surgery you want, but if you don't really reverse the immunosuppression, you're not going to really be helping these patients. Because at really end of the day, you do leave some degree of fungal debris, let it be microscopic or not, and it still can be quite detrimental if you don't reverse immunosuppression. So at the end of this case, you'll see what we try to achieve. But we are quite aggressive in this case. We remove everything as much as we can, removing the entire septum, and really there's no goal of functionality, but really to save this individual. As you can see, when you're cutting out necrotic tissue, it doesn't bleed, and really the end surgical goal is to achieve bleeding tissue. Obviously, there's sometimes some limitations on what you can do with endoscopic approach, which includes the orbit and intracranial components. And when you get to those components, you may have to ask for help. When we have orbital involvement, we tend to get our head and neck colleagues to consider an orbital exenteration. When it's an intracranial component and we're removing the skull base, we tend to get our neurosurgical partners. But when we do those types of surgeries where we're doing orbital exenteration or an intracranial component, we also have to we rediscuss the scenario with the family members, because the morbidity of those surgeries and those outcomes tend to be much more poor. Again, we try to balance what's the potential outcome for this patient with the degree of surgery. So you can see this individual that we first examined, it was potentially bilateral. I'm almost essentially doing an endoscopic craniofacial resection for this individual. And postoperatively, this is what we achieved for this patient. Now, the biggest concern for this individual was when I looked at the skull base, it was still going up that septum. And as you can see, this is the right and left side with the septectomy. The midline, the septum is still dark and eschar and no bleeding. At this point, we had to have a rediscussion with the family about the extent of surgery. And this is, I keep this in my back pocket, that I tell all patients' families that I will be likely talking to them intraoperatively, that if I do find any concerning findings beyond the nasal cavity, that we'll discuss the extent thereafter. When it comes to microbiology for these conditions, again, there's kind of two different categories. There's mucor and there's aspergillus. When you have the neutropenic patient, you're dealing more with the aspergillus family. When you're dealing with the diabetic ketoacidosis family, you're dealing more with the mucor patient. So that's like rhizopus, rhizomucor, obsidian mucor. And what you see, which you can see on this H&E, is that this fungal debris causes invasiveness into the vessels, resulting in thrombosis and infarction. And that's why you see that endoscopic picture and those findings that we see in surgery where you get no bleeding. Now, Dr. Nayak from Stanford does have a paper out there that talks about pre-invasive fungal disease, where the fungus does invade into the tissue, but not into the vessels, causing the thrombosis. And it's kind of a concern that at least that I think about when I think about an immunocompromised patient with a fungal ball. These patients, even though they have no findings of invasive fungal disease, I do put them up my surgical wait list for management, so that in the case that this does potentially convert, that I've already managed them for their fungal ball and possible risk factors. Now, this is a finding of aspergillus on KOH mount. You do find those typical findings of branching seen here. Now, in terms of postoperative management, I think antifungals, as we mentioned, it's a key component in the medical management. Again, it's kind of broken into those two categories. We're dealing with mucor or dealing with aspergillus, at least when it comes to our infectious diseases team. Amphotericin B for the mucor and voriconazole and itraconazole for the aspergillus. When it comes to amphotericin, you can have a more expensive option, which is the liposomal drug. The benefit of that is less nephrotoxic and it has good CNS penetration. So the key take-home message, invasive fungal disease is bad. In the literature, the mortality is about 50 to 80%. The clinical features to consider is that the people can have fevers, but not responding to antibiotics. They can have some facial periorbital swelling. Definitely high suspicion when you start seeing cranial nerve deficits and CNS involvement. From a medical history, obviously immunosuppressed. Imaging, that's the key part here. The CT can be really unremarkable, and as you can see from our case, it's pretty unremarkable for a few days. And I think that the reason our individual in this case didn't have a good outcome because the CT findings on the first day were unremarkable, but there was no examination of the nose. And the treatment requires early aggressive surgical management and obviously medical management as well. And with that, thank you very much for having me. Stop share here. There we go.
Awesome. Andrew, I just was hoping you could comment quickly on the importance of biopsy and culture intraoperatively to help guide ID.
Yeah, for sure. So, even before the operation, if you can, we take a biopsy. It just increases that suspicion. But even if the biopsy was negative, if I have a high clinical suspicion, I still go into the operating room. And then intraoperatively, definitely you're taking that the biopsy and cultures because again you want to differentiate between aspergillus and mucor. I think that helps infectious diseases direct their management for the management of these individuals. Now I know we want to talk about COVID and the scenario where we do talk about these case presentations. We did have a case of this 2 weeks ago, and when you have obviously clinically there was a high clinical suspicion. It was an sphenoid sinus, so obviously on initial endoscopy in the bedside there was no findings of acute invasive fungal disease. We couldn't take a biopsy. We got an urgent MRI just to see the extent of what we're dealing with. Obviously the MRI also has findings of acute findings of acute invasive fungal disease. We still got COVID testing, but the problem with our facility takes about 24 hours to get that result back. We proceeded with surgery using our PAPR. So it depends on your facility, depends on the access to getting COVID testing. I think these patients need acute care. Every day you wait, their outcomes get worse and worse. So facility dependent on your access to COVID testing.
I had a patient for mucormycosis. It's tremendous behavior of this disease is very impressive. It's very quick. I was fascinated by how this patient was immunosuppressed. We were unable to address what was having because we did a swab, and unfortunately, it seems that on a swab it doesn't report any kind of this. You have to take a biopsy. It was exactly what you just said. It's very aggressive. The patient developed a palsy of the abducens nerve, and then was inside of the cavernous sinus in just 4 days, and was completely strange things. So thank you, Andrew. So let's go ahead, and I think that Joshua, would you like to say something more with Andrew, or we can skip with Sonya?
Yeah, let's get Sonya going.
Okay.
So you're having a small part of it. I think that you have to exactly rescale it. Thank you.
Okay. So hello again, I'm Sonya Marcus. I'm a new assistant professor at Stony Brook University, which is located in Suffolk County on Long Island. For people that don't know where Long Island is, you can kind of consider it a suburb of New York City. So we actually have a lot of COVID at our hospital and pretty much are doing no elective surgery at all. I want to thank the ERS for having me here today. It's a great honor. And just a disclaimer, I am very pregnant, so I get short of breath pretty easily. So if I have to stop, just let me catch my breath. No disclosures. So when asked to talk about kind of emergency scenarios, I chose carotid injury, not because I have a ton of experience or am necessarily an expert, but I think it's something very important to know how to manage, and I will be kind of using a case to present this. It's kind of like, you know, an acute airway emergency for just kind of general otolaryngologists, in that you may never encounter it, you may only encounter it once or a handful of times, but if you do encounter it, you want to kind of have an idea of how to manage it. So I thought it was important to present. So in general, how often do we see this? It's likely underreported. In kind of general sinus cases, it's limited to just kind of case reports. There's not really a true incidence reported in the literature. And this may be decreasing over time with improvement in instrumentation, as well as kind of improvement in our training as we kind of learn more and more about how to do sinus surgery. But it certainly can happen, especially if you're working in the sphenoid. Pituitary and like more routine pituitary surgery, it's been quoted to be, you know, less than 1%, around 1%. I think even Nick did a study surveying skull-based surgeons about this. But, you know, as pituitary surgery becomes more and more prevalent, especially endonasally, it's not only being performed in high volume centers, it's also being performed more widespread, and additionally by non-fellowship trained rhinologists. So it's also something important that people know how to manage because it can happen. And then if you're someone that does more significant skull-based surgery, it can be quoted up to 5 to 10% of carotid injury. But arguably, if you're doing kind of more complex surgery, you may actually even be more prepared to deal with this complication because you're seeing this regularly and you're more familiar. So again, you may not, you know, encounter this very often, but it's one of those things that if you do encounter, you want to have some confidence in dealing with this. And the reason why it's so important is it has a lot of morbidity and potential mortality. Mortality rates have been quoted up to, you know, 20%. You can have permanent neurologic morbidity and pseudoaneurysms that you have to deal with postoperatively up to 60%. So I'm kind of going to talk about a case that I was involved in my training. The point of this presentation isn't really to discuss specifically this case or the indications for this case. And in fact, I have video associated with this presentation that is from a friend. It's actually not this case because we weren't able to record during this case, but I'll use this as kind of the example. This is a 60-year-old male. He had a petroclival meningioma who ultimately underwent 2 separate surgeries to debulk. The first surgery was a petrosal approach, which I was not involved with. And the second surgery was an extended endonasal, transclival, transtuberculum, transplanum approach to debulk for brainstem compression and optic apparatus decompression. This is just to give you an idea, it's a large tumor. Don't have to go into much specifics here. The goal of this talk is more so to talk about intraoperative management, but this is just kind of a disclaimer up front that kind of the saying, the best defense is a good offense. So, you know, planning preoperatively, looking at your scan, knowing your anatomy, if it is a bigger tumor, talking with your neurosurgeons, getting imaging, potentially considering balloon occlusion testing, using image guidance, neurophysiologic monitoring. These are all things that you would want to consider preoperatively if you knew you had a more complex case. And then, you know, in general, again, disclaimer, you know, there are many ways to handle kind of arterial injury, but if you're not expecting to kind of sacrifice or bypass in the preoperative, make that decision preoperatively, ideally, if you encounter an injury, you would like to pursue, ideally, a vessel preservation technique. And we'll go over kind of what those are. So in our case, we raised a nasal septal flap up front, we widely exposed, we removed clival bone, and then we started to decompress the right carotid, and then we noticed some abundant bleeding. So kind of how to manage this. So again, this is not associated with this case. So this is just kind of show kind of how profusely this bleeding is and what the bleeding can look like. First you want to make sure you recognize that this is arterial bleeding. And as you can see, it fills up pretty quickly. I've seen videos where it can fill up even more quickly. And if you take your endoscope out and reposition, the cavity can fill up quite quickly. So this can be very scary and difficult to manage if you're not familiar. So from an ENT perspective, it's very important to gain visualization with the goal of gaining hemostasis and then using your anesthesia to help kind of keep the patient perfused and safe. So, initially, you really want to maximize visualization. This is ideal if you have a 2-surgeon team approach, then you have 4 hands. If you encounter kind of carotid bleeding during a sinus surgery, this may not be possible. You may be alone. However, in those cases, the injury may be smaller. It's very likely extradural, so it may just be easier to pack those patients. But if you have, more hands, that's ideal, especially a neurosurgery colleague. You can put the endoscope on the side that is less profusely bleeding, kind of blocked by the posterior edge of the septum. And that person can also be holding a suction in order to direct blood away from the endoscope, while the other surgeon is working on the side of the carotid to, locate the site of the injury and control the bleeding. Using an endoscopic lens cleaning system like the endoscrub is very helpful and can minimize kind of, coming in and out of the field to minimize disruptions. Kind of having large bore suctions available is very important. Also letting your OR staff know so they can kind of empty the canisters so you don't lose suction. They can check connections to make sure you're not having any issues there. And then there are some reports of using kind of common carotid artery compression in the neck, though you're probably not going to have a lot of hands for this, or it's probably not going to help all that much. So, once you kind of gain visualization, your goal is to kind of really just stop the bleeding as much as possible or altogether. There have been systematic reviews about this, as well as a lot of studies from our Australian colleagues on sheep models. In general, getting direct pressure with pledgets is very helpful. And then, from these systematic reviews, we've seen that people tend to want to use gauze. Gauze can be an issue because if you overpack, you can actually cause morbidity. So it's a very delicate balance. So we've kind of moved away from that and tried to figure out other ways to help injury without kind of overpacking. Sheep studies have shown that kind of Surgicel and Flow Seal are not very effective and don't really stop carotid bleeding. Mirasil kind of goes along with gauze, not very helpful. Crushed muscle has been shown to be very helpful. Crushed muscle can release calcium, which can promote a fibrin plug and promote arterial patency. And you can obtain this muscle kind of from many different locations, from temporalis, from SEM, from abdomen, from thigh, even the tongue, which is what we ended up using. A lot of that will probably depend on what you prepped out during the surgery. So if you're going to use abdominal fat, you might have the abdomen prepped out. If you were going to use fasciolata, you may have the thigh prepped out. Bipolar electrocautery can be used if you have a perforator off the carotid or a very small tear. However, studies have shown that it's not particularly effective and could cause more problems down the line, like pseudoaneurysm down the line. Endonasal suturing can be an issue. Medtronic used to make something called the U-clip. I don't think it's made anymore. I've never seen this be done, but I would imagine this takes a lot of technical skill, and you would need probably pretty wide exposure of the carotid in order to be able to facilitate this. Aneurysm clips can be used, especially if you are prepared and have them in the room and you're with your neurosurgical colleagues. And then ligation. Some other things to consider in case you're unfamiliar. You may think that you want to bring down blood pressure, but actually you want to maintain normotension. You want to maintain cerebral perfusion. You may even want to bring blood pressure up a little bit since they are probably hypotensive because they're losing so much blood. However, if your field is kind of inundated with blood, and I don't have personal experience with this, but I know neurosurgeons use adenosine for aneurysm cases, and it's used in some of the bigger skull base centers. And this was reported in IFAR this past year about using adenosine. It's something you talk about with your anesthesiologist. And you can get transient hypotension for about 60 seconds, enough to put down a muscle plug. And that's what was done in this case. So this case, again, is not related to my case, but just kind of shows kind of how much blood can pool. In this case, I think it was a bigger tumor. I don't know too many details, but a lot of the carotid was exposed. And you can see it can be very difficult to maintain pressure. There was attempts to bipolar, which were not super successful because the bleeding was too much. And then, I mean, obviously there was excellent visualization throughout this. And then they were able to place clips proximally and distally. In our case, it was more of a kind of a punctate hole, and there wasn't as much bone removed off the carotid. We had 3 people in the room, so we were able to harvest muscle from the tongue and demucosalize it, and then put packing over it before bringing the patient down to the angio suite. Postoperatively, we brought the patient to the angio suite. Immediately after, there was no extravasation or pseudoaneurysm, so we left the muscle and the packing in place. The patient had a repeat angio 1 week later, however, and did have a pseudoaneurysm, so highlights the importance of kind of following these patients up to make sure there's no issues, and did end up undergoing a pipeline embolization, and then subsequently went to the OR for removal of packing, and then there was no bleeding noted. This patient did very well, had no new neurological complaints, and so everything ended up being fine because everyone that was involved was more comfortable with this complication. So there's been a lot of algorithms from people with a lot more experience than me. And in general, kind of highlights kind of the importance of what you do intraoperatively. It's important to kind of involve all staff in the operating room. So you, as the surgeon, you kind of know what you're going to be doing. You want to be calm, get your visualization, get your hemostasis. You want to let your anesthesia team know what is going on so they can maintain the patient. And you want to let your OR staff know as well so they can make sure that everything is connected. They could potentially call for new staff. They can make sure all your lines are set up. And then this algorithm is from the Pittsburgh Group, which is excellent, and also kind of goes through kind of what you should do kind of intraoperatively in terms of managing these injuries, as well as what to do postoperatively, widely quoted in the limited literature that we have on this topic. And so that is all. Thank you.
Thank you very much, Sonya. And I think that we are perfectly on time. It's like a miracle. And you were great. And of course, thank you, Joshua, because I think that you, because of your previous participation, you explained to our colleagues how to manage it well. So in order to address some questions, I would like to start from Nick. Before that, Joshua, would you like to ask anything from your perspective to our colleagues, and then I will proceed for the question?
No, I'm interested to hear what questions you have.
Okay, so let's start from the first one in order to do it. So this is a question coming from Brazil. What is the preferred, and it's for Andrew, what is the preferred imaging study for detection of fungal sinusitis?
Yeah, if you think about imaging of MRI, CT scan is not going to help you, just shows mucosal thickening. MRI will. If they have decent kidney function, we do get MRI with GAD, but obviously the person that's diabetic or poor kidney function, they tend not to have the the optimal kidney function. We end up with just MRI without contrast.
Okay. Anyone else would like to address more specifics in this before going to the second questions? Okay, I have one. Due to the fact that we are always providing instructional suggestions to our attendees, would you recommend there's a sign that could be specific to recognize if it's a fungus or not, like signal voids or something like this?
Yeah, I wouldn't call myself a pure expert when it comes to the MRI, to be honest. I do struggle as a surgeon differentiating that sometimes. Signal void is the most common, I think, when you treat with fungal debris. But I think it's difficult. I honestly think that a lot of times even the MRI report even is not conclusive. A lot of times they based on the history that you place on the MRI on requisition. So signal void when it comes to debris.
Yeah, I want to just second what Andrew said. MRI is definitely helpful in confirming if you see a signal void. However, it really highlights for me the importance of endoscopy and taking a true look at the mucosa. Yeah. That's going to be the highest sensitivity to help you determine next steps.
Good. Another question also for Andrew. It's from India. Are you using antibiotics in patients with invasive fungus sinusitis?
We're not. We're pretty aggressive with the again, depending on if it's mucor versus aspergillus, whether we go with amphotericin versus voriconazole. And the key part here is it's a team approach. Like you are a surgeon, you are operating, you got to get infectious diseases and making that last call. I don't, to be honest, as the surgeon, take the responsibility of making that decision of what's the antibiotic or antifungal, but all of our patients, last 3 cases, none of them were placed on antibiotics, they were placed on antifungal therapy.
All right, so let's skip and just pass the torch to Nick. So here's the question, comes from India. How would you manage JNA bleeding?
So that's isn't that a different topic you'd have me back for? So JNA, subject that's actually near and dear to my heart, is challenging. And I think that if you go back to the Pittsburgh Group, which I am heavily biased for, I trained there with Carl Seinerman and Paul Gardner, but their staging system is based on the fact of doing a preoperative angiography and embolization. So I think that's critical in the management of JNA bleeding. And then there's all kinds of new tools available intraoperatively to control bleeding. I think that the vascular control should really be the first step of the operation. So exposure around the tumor, control the blood vessels where you can. I personally prefer to use a coblator to manage the bleeding associated with these tumors. They are very difficult to treat regardless of your surgical skill. Even if you're an expert surgeon, they can be really challenging. And so sometimes it's worthwhile considering staging the surgery. If you have an excess amount of bleeding, remember that it is a pediatric patient. They can lose a tremendous amount of blood. And so I would say that's my strategy for intraoperatively. If it's in the clinic, I would pack their nose just as I described, and use the tried and true methods that we have, and maintain focus on protecting the airway. You know, that always comes first. Look at their vital signs and make sure the patient is doing okay, not just their nosebleed. That's my general approach to that.
So what are from the others speakers? What would you suggest also?
Yeah, I think Nick hit it. Like, I think preoperative embolization is key. I think the other part to also consider is, end of the day, I think these things still bleed, and that's usually coming from the Vidian artery, because it's coming off the internal carotid artery. So like that's usually an area where you do get the bleeding from, and usually I keep that to the end. So I'm usually dissecting out that tumor, removing the tumor, debulking it. The anterior part tends not to bleed, but once you get to that sphenoid component where it's kind of being fed by the Vidian artery, that's where you kind of have to move fast, and that's where you start to use the coblator or the bipolar, et cetera, to kind of achieve hemostasis. But it's all just being mentally prepared of when the bleeding is going to occur. I think it's also key as well.
Okay, so Joshua, Sonya, anything else?
No, I agree.
Good. All right, so let's skip, and this time is for Sonya. Um, this is from US.
Okay.
Would you recommend transfusion during bleeding?
Yeah, if anesthesiologists are monitoring hemodynamic parameters and they notice a need for transfusion, I would certainly, recommend that. And that's why I think communication with your anesthesiologist is so important. That they have to know what's going on, kind of communicating with them how much blood you're losing, and so that they can be actively participating and making sure that the patient is, perfusing well.
All right. And another question from France. Medical legal aspect, would you recommend a neurosurgeon to be present during a suspicion of carotid invasion?
Me personally, yes, I would certainly have them involved. I can't speak for everyone, but especially as a brand new attending, I would certainly have a very low threshold for involving neurosurgeon. And I probably throughout my entire career, I'll probably have a neurosurgeon available for that particular situation.
I would love to ask to the other speakers, because that's very tough one. I would, of course, have it. What about your opinion, Andrew, Nick, Joshua?
Yeah, I would. I think, I mean, you're a young faculty. You have nothing to hold your hat on. I think at the end of the day, you ask for help. So preemptively asking for neurosurgical involvement, but also if you're not comfortable in the neck, say if you're a purely endoscopic surgeon, you don't spend much time in the neck, and you need to get distal control, like also ask for help in terms of having your head and neck surgeon involved and happily available, so that you can get distal control is also beneficial.
Nick.
Yeah, I'm a very big fan of. I'm sorry. Go ahead, Nick.
Josh, it's all you.
I was just gonna say I'm a very big fan of having the most experienced, most competent surgeon in the room at any time. I have never run into a situation where someone faulted me for that or begrudged the decision to call in for a second set of eyes. That being said, though, I think there's also an interesting point or discussion to be had about patient selection. And if we do see invasion, frankly, through the wall of carotid, I think you really have to have a discussion of goals and the huge risk of complications with the patient before rushing to the OR.
Yeah, I would take everything that you guys said even a step further and say that I am a huge fan of a team-based approach, and going back to what I said before about having the appropriate surgical team. And so regardless of the skull-based pathology, big or small, there are certainly cases that I know that I'm comfortable dealing with as a one-handed surgeon, who's holding an endoscope in one hand and doing the surgery with the other hand. And I know that's within my wheelhouse. Examples are like small encephaloceles or spontaneous leaks. I'll perform them with my neurosurgical colleague in every situation, so that we're always prepping for when one of these, God forbid, catastrophes happens, we are prepared. And I think that's really important, and that's my personal philosophy on some of these skull-based cases. So carotid invasion is certainly one of them if I need to be in the OR for that purpose. Hopefully we'll have already prepped in a more benign situation.
So we are perfectly on time. So I'm always concluding every panel asking from the panelists in that can I refer every one of you for any other questions from the audience, because due to lack of time we have to switch and close this panel as soon as possible. So many questions has been requested, but we cannot provide those answers. So I would love if you could be able to address those questions personally. Those are emailed. Perfect. I'm really glad that Joshua, I'm very fascinated that everything has been done properly. So thank you so much for providing your email. It's unbelievable, and I really enjoyed that. Before closing the remarks, before closing the whole panel, I would like to ask a question from all of you. because of this pandemic period, would you agree or would you address for the administration to have a look for the um, how to say requests from the patients or the consent for any kind of procedure? Would you think that we have to change some our attitude, or do we have to change our informative for the patients during this pandemic?
Oh, yeah, I think that we do. I think we have to kind of let patients know about the increased risks that we're seeing from this pandemic. Um, I know that if any surgeries are scheduled, patients are counseled about the fact that they will be potentially in contact with COVID positive patients. They have to kind of, especially if it's a more elective procedure, they have to be aware that there are increased risks. As we're starting up our clinics, we're testing all patients for COVID prior to them entering the clinic. If there's any question, they're usually screened through telemedicine, whether or not they want to come in, whether or not they want to undergo an endoscopy. So yeah, I think it's important to let patients know where increased risks are and if they want to take them.
So what's your suggestion, Joshua? Would you express something about it?
Yeah, absolutely. Exactly what Sonya said. Emory, actually, for the patients, we're currently operating on those that we consider the surgery to be essential. So it is a step down from emergencies, but cancers, disease that will clearly advance if we don't intervene. For these patients, we actually have a scripted consent that includes the understanding that should anesthesia be needed prior to your surgery, it may be canceled at the last moment. You may be hospitalized with a COVID positive patient directly next door. Just really, I think, very fair, but very extreme warnings. And just to credit you, Puya, in putting this together, I mean, this situation just increases the reliance that we have, or the dependence that we all have on each other, and working as a community to both understand what's going on and to define best practices going forward. I think this is a huge shift in all of our practices.
What's your experience, Andrew?
Yeah, I mean, kind of what Josh said. I mean, our practice is only semi-urgent cases right now. We haven't opened up to elective cases, so we haven't really, I mean, we haven't been in the full details that Sonya and Josh, I think, are describing, but inevitably, as we start opening our practice, I think those discussions will happen, but I think it's important. I agree.
What about Nick?
Very similar. Johns Hopkins is very, very involved in the management of this, and the NIH is right down the road, where about half of our faculty practice. They have appointments at the NIH as well as at Hopkins, and we've adopted really similar practices to that's what's been described. We counsel all of our patients on it. I go out of my way to talk about the personal risks, and I think the patients understand it when if I am in a situation where I'm performing nasal endoscopy in the clinic and I'm in full PPE with a face shield and a disposable gown and headgear and shoe covers, all the things that we've described, have been described all around the world. I think also that's another message that we send to our patients, in addition to physically talking to them about it, that this is, this has changed practice for sure.
Yeah, by the way, it's very tough to work 8 hours straight with a whole PPE and mask and stuff. It's very frustrating. Even for me, you might not know, but I've been recovered after COVID-19. I was one of the first one to be with that, but I still have to wear a mask and blah, blah, blah. So I'm not immune to that. Thank you so much from the association. And thank you, Nick. Thank you, Sonya. Thank you, Joshua. Thank you, Andrew, for being with us. We are perfectly on time. The whole panel will be also shared on our Facebook channel, so will be available for consultation, for future consultation. I would like to address a few points, a few appointments. next Monday, we are going to, I'm sorry, for the next Wednesday, we are going to have another panel for endoscopic middle ear anatomy, part 3. Then we are going to have another endoscopic dissection teaching step by step by Janakiram. Then we have Preoperative next week. Then we are going to have Paola Battaglia and Jacopo Dallain for a supracellular lesion and for reconstruction. And in about an hour, we are going to have another panel from my maestro Paolo Castelnuovo for skull-based procedures during COVID-19. Thank you so much, everyone, for participating. Thank you for the attendees, and I hope to see you very, very soon.
Thanks so much.
Goodbye.